quite interesting. He mentioned that I'm now president of the American Institute of Ultrasound and Medicine, and it's extremely interesting to hear these presentations, to meet people, many of whom, well, some of the students weren't born when I got into ultrasound as a resident in 1979, doing an elective at Parkland Hospital where I'd been an intern. And it was all sort of the first real-time equipment had just first come out. And it is so interesting over the years to see different applications in different fields and different users who, when the technology is placed in their hands, what they realize they can do by looking rather than auscultating or palpating. And it is exciting, but in some respects, certain fields and certain applications are reinventing the wheel. And so having the breadth of time and longevity, and I will share some of that with you, but it is extremely exciting to see the passion and enthusiasm of trying to spread this modality. And I agree that the technology and the change in the equipment to making it smaller and more portable, yet having the quality to really do the kind of imaging that we need to, is just causing a revolution in so many arenas and so many areas. And I appreciate so much Susmi and Dick Hopman giving me the opportunity to now become part of this movement, because I think there's no question, and the area that I think is the most exciting, however, is the concept of teaching undergraduate medical students. And forgive me, I was on the treadmill this morning, was a paramedic as I was doing the elliptical from Carolinas Medical Center, and I realized that this is not simply going to be medical students, but this will be all kinds of healthcare providers. But the concept of using ultrasound to teach, to me, is something that I've just discovered in the last couple of years, thanks to Dick, that is truly what's going to be the most disruptive of the technologies and will enable people to then use the modality in clinical practice. But the title that I've been assigned is Why We Should Think Ultrasound First. And I think that I would be remiss if I didn't tell you that at New York University School of Medicine, our main teaching affiliate is Bellevue Hospital, which is the oldest city hospital in the country. And we get a lot of really good residents in obstetrics and gynecology, because there's sort of a saying, if you don't see it at Bellevue, you won't see it. There's just all kinds of pathology is frequently coming in. And recently, this elderly woman having her first baby came into the Bellevue emergency room in active labor. We delivered a 9-pound, 12-ounce bridge using welding equipment. We're not sure who the father was. But you didn't hear about this down in South Carolina, huh? All right, well, anyway. So when I think about ultrasound first, the things that come to mind are broad stroke issues of safety, which was how it began, the original concept, cost, and then finally point of care, which is really the most exciting area. Many people in the beginning were just talking about using ultrasound instead of CT or MR or PET. But I think it goes way beyond that. But that part of it was in talking about the fact that ultrasound is not ionizing radiation. And certainly this is extremely important in obstetrics, the developing fetus, and in children. The whole concept of image gently and using ultrasound instead of CT scan in these developing children. We know that ionizing radiation's cumulative dosage can be harmful as it becomes greater, and this becomes a significant issue because there's been a huge increase in the application of CT in emergency medicine, not perhaps in this group, but in this country it seems that you can't get out of an emergency room with anything between the neck and the groin without a CT scan of the abdomen and the pelvis at the same time as they do your routine bloods. In addition, the annual mammogram, as these things get younger and younger, add up to be a lot of radiation. Finally, it's less likely for information to be fumbled in the handoff. You know, in the example in my field of gynecology, a woman came in and she was had a positive home pregnancy test. She's staining, therefore she's potentially an ectopic pregnancy. You send that to the radiologist. The radiologist performs an ultrasound. The radiologist generates a report. It comes back to the doctor. That dissemination of information certainly can allow for some human error or some misunderstanding, or what I'm calling here the fumble in the handoff. In terms of cost, there's no question that the per-use cost of ultrasound significantly less than higher imaging forms like CT or MR. The equipment itself is considerably less expensive than CT or MR. And much of ultrasound, and here we talk about point of care, does not require a technician, and certainly the preferred term is sonographer. It's interesting that Dr. Hoffman uses that phrase. You know, a sonographer to me, and I was on the board of the ARDMS for 12 years, is a highly trained medical professional who performs the examination. And I think of point of care as not requiring a sonographer, and that's done by the clinician, him or herself, who will institute that information. And I think that that's a very important distinction. And so finally, we do move into the concept of point of care, and this is defined as ultrasonography performed and interpreted by the clinician at the bedside. And this is perhaps potentially the most significant change in our diagnostic paradigm. And I think it certainly allows us now to marry the concept of what does the image tell us, and then immediately going to the diagnosis. There's no longer this dichotomy. And so the old paradigm when I went to medical school was you approached a patient, you did a history, you did a physical examination, and then you determined what laboratory tests you were going to order, and certainly an ultrasound examination was a laboratory test. The new paradigm for me is you do a history, and then you perform a physical examination which will include imaging. This is no longer a laboratory test. So 25 years ago, I wrote, quote, "There is a difference between an ultrasound examination by referral with a report," what I just described to you, sending this to the imager who does an examination and sends you back a report, and examining your patient with ultrasound. You know, it may sound like smoke and mirrors and doublespeak. It is really the basis of point of care ultrasound. We are examining our patients with ultrasound. Now, let me apply this to my area of medicine, and I realize there are very few gynecologists in this audience. There don't need to be, but many of you are in medicine and understand the bimanual exam, which has been the way the pelvis has been approached for hundreds of years. In addition, I want to expose you to the concept of a simultaneous assessment of anatomy and physiology. So the bimanual exam, if you haven't done one lately, is performed with 2 fingers in the vagina and 1 hand on the lower abdomen in an attempt to mentally appreciate the status of the female pelvic organs, mainly the uterus, ovaries, and potentially fallopian tubes if they're abnormal. So if you think about what is the doctor doing when they do a bimanual exam, and I've divided this into an objective component and a subjective component. The objective component, is this uterus enlarged? Is it irregular in shape? Because might there be fibroids? Is this ovary enlarged? And if it's enlarged, is it cystic or is it solid? The subjective portion, is there normal mobility to these organs? Is there tenderness in the pelvis with these organs? And it's my thesis that with transvaginal ultrasound, if you've got the equipment at the bedside, you can obtain the objective portion literally in a matter of seconds. The subjective portion still requires nuance and experience on the part of the examiner. But in addition, our ultrasound can give me information about physiology in addition to anatomy. And so what I often say is the pelvis is a dynamic place. It undergoes a cyclical journey every month, usually culminating in a menses, sometimes culminating in a pregnancy. And our transvaginal ultrasound can give us information about function in the pelvis, as well as simply the anatomy, the size and shape and consistency of the structure. And there should be total synchrony between the ovarian hormone production and its endometrial response. Not to mention some more subtle findings like perhaps fluid in the cul-de-sac behind the uterus after ovulation, or the presence of endocervical mucus, which you want to find pre-ovulatory. And so, this isn't going to do this to me. Sorry. Technology at its best, right? Here now is an ovary, okay? This is a normal-sized ovary. these sonolucent follicles, this is very early after the menses has ended, maybe day 5 or 6. Each ovary recruits a number of these follicles. When we look into the uterus, here's the uterus in long axis, here's the muscular coat of the uterus, and here is the endometrium, which is what is shed when one gets their menses. And we see that the endometrial echo here, under the influence of estrogen early in the cycle, is fairly thin and not all that well developed. There is synchrony. As we move closer to ovulation, one follicle will become dominant and develops to about 25 millimeters before it bursts. You only want one follicle to burst, otherwise you would get fraternal twins. And we look for the response in the endometrium, and you can see now the central midline echo here, and we've got this multi-layered halo effect, and here's the basalis on the other side, and this is a very typical pre-ovulatory pattern of the endometrium. After ovulation, and this is now the corpus luteum, which is Latin for yellow body, it is a thick-walled crenated structure. My nurse once said it looks a little like Batman's cape, and there is intense vascularity surrounding the corpus luteum. So we use color liberally for its morphologic characteristics for the presence or absence of blood flow, and we see a fiercely echogenic response of the conversion of the proliferative endometrium to the secretory endometrium. Now, there are a few somewhat unnatural situations. Here's a patient on birth control pills. Yes, you can see a few small follicles contained within her ovary, but the pill works by keeping the follicles from developing. So none of these follicles should be more than maybe 10 millimeters. And the endometrial response is also quite unnatural. It's very, very thin. And actually what you have is a progesterone effect, even though you don't get any proliferation of this endometrium. Or when we become menopausal, I hate to say also a somewhat unnatural characteristic. Most primates don't live much beyond their capability to reproduce. Modern medicine has women living 40 years in a post-reproductive state. But here's the postmenopausal ovary. It's got none of those follicles because that's the definition of menopause. The ovary is no longer capable of producing that, and there's no response at all. This thin white echo is actually the interface of two sides of an inactive endometrium because there's no estrogen stimulation. So I'm showing you an example. When I was in medical school, you know, I had to take notes, and maybe they showed me a picture in a book or a histopathology slide of these things. And I am now taking you on a tour of normal pelvic physiology and anatomy. This is the way that students need to be taught about what happens in the pelvis. I want to use another powerful example, though, of Ultrasound First in gynecology. When NYUMC put together its forum last year, most of it was, as I pointed out to you, was talking about the advantages of ultrasound over higher imaging forms. Appendicitis, using ultrasound instead of CT. Uterine malformations, using ultrasound instead of MRI. I came along and said, but wait a second, one of the areas that I've published on that's been just a game changer in the last 20 years is ultrasound instead of endometrial biopsy. And so indulge me for 5 minutes or so to take you through the history of where we have come in an area that's been extremely important to me. In gynecology, a woman who's menopausal who bleeds is considered to have endometrial cancer until proven otherwise, and this is always mandated in evaluation. The reason for this is endometrial cancer is the most prevalent gynecologic cancer, fortunately not the most lethal. Although everybody needs to be evaluated, about only 3 to 7% of those patients will end up having an endometrial cancer. Most do not. The problem in the past for this so-called endometrial assessment, much of it was done with a D&C, a dilatation and curettage. What they used to tell patients was a scraping. This was first described in 1843 and was the most common operation performed on women in hospitals through much of the 20th century. Then came along these smaller suction piston biopsy instruments. They were cheaper, they were disposable, they were little plastic catheters that had an internal piston to generate the suction. And there was one particular brand called Pipel, which was so successful it became a verb. Our residents would say, I pipelled the patient. And it was ironic because even though they might have been using a competitive brand, it was a little bit like you say, I'm going to the Xerox machine, but you own a Canon. Or hand me a Kleenex, even though you have Cottonelle brand. And this is how successful Pipelle became, basically because of one paper that came out in 1991 where a guy named Tom Stovall took 40 women with known cancer, and he did this Pipelle biopsy in the clinic the week before their hysterectomy. He got cancer in 39 of the 40 patients, hence he said it was 97.5% accurate. And ads for this, 97.5% accurate, were in every of the throwaways, OBGYN News, Contemporary OBGYN, Female Patient, for the next half a decade. And so everybody sort of jumped on doing this as a diagnostic test. Mainly because of this widespread promotion and easy use, it became, with no further validation, quickly the standard of care for evaluating postmenopausal women who had bleeding. There were some other papers that did similar things. Here's a guy named Guido, and this was extremely interesting. This got me on the track. He did the same thing that Stovall did. He took 65 women who had known cancer. He went to the operating room, and before their hysterectomy, he did this biopsy with this device. He missed 11 out of 65 cancers. That's not 97.5% accurate, but he did us the favor of opening up the uterus after he did that. 3 of the cancers were less than 5% of the surface area of the uterus, another 4 were less than 25%, and another 4 were less than 50%. And of 11 cancers in polyps, they missed 5. So he concluded that this Pipelle biopsy was excellent for detecting global processes in the endometrium. Other people did the same kind of a study in patients that had known cancer by doing a biopsy. Here they missed 7%, here they missed 17%, here they missed 33%, not nearly as reliable as that original paper that got all the publicity by that guy Stovall. Well, the newest American College of OBGYN guidance in July 2012, though, now references the fact that when the cancer involves less than 50% of the surface area, this blind biopsy is not as reliable as previously thought. And it was extremely gratifying to me when they said, quote, a blind biopsy that does not show cancer or complex atypical hyperplasia cannot be considered an endpoint. Well, what about transvaginal ultrasound? These were introduced in the mid-'80s, and realized that our vaginal probes utilize higher frequency transducers that are in closer proximity to the structure being studied. And in my first book, I coined a phrase, sonomicroscopy, because I put forth to you that there is a degree of image magnification that you could not see with your naked eye if you could hold the structure at arm's length. So for instance, here is an embryo of 2.5 millimeters at 45 days from the last menstrual period, in which cardiac pulsations are clearly visible. I mean, if you could hold this structure in your hand at arm's length and squint at it, you would not appreciate cardiac pulsations contained within a 3 millimeter embryo. We're doing ultrasound through a low power microscope. We are seeing every little blemish that the body has to offer. Therefore, we must understand what's normal, what's the background noise, what's accepted, and what is pathologic. But in the early 90s, transvaginal ultrasound was utilized in these women with postmenopausal bleeding, mainly to see if it could predict which patients lack significant tissue, because most of them bleed from atrophic changes rather than really having any endometrial cancer or pathology. And if we could predict which patients were okay, they could avoid what had been the D&C or then the biopsy, its discomfort, expense, and risk. Consistently, the finding of that thin white line, that endometrial echo less than 4 or 5 millimeters, was shown to effectively exclude significant tissue in these postmenopausal women with bleeding. And so here's a 66-year-old woman who comes in and says, I had a stain in my underwear. She's cancer until proven otherwise, but she's got this thin endometrial echo. Here's another example of an atrophic endometrial echo. And here is an example, once again, of a postmenopausal woman with an episode of bleeding who has no pathology and doesn't need anything done. There's been validation of some of those earlier studies. Most of this comes out of Europe. The Nordic trial, 1,168 women with bleeding. Enrico Ferrazzi in Italy, 930 women with bleeding. The Scandinavian people. And if you look at this, for an endometrial echo less than 4 millimeters, the chance of having a cancer was 1 in 917, infinitely better than that false negative rate that I showed you, even in women with cancer when you do that blind biopsy. Is it even worth it to do a blind biopsy? If you've got inactive atrophic tissue, one study showed that 82% of the time it was performed successfully. 18% of the time these were so atrophic they couldn't even get into the uterus. And when they got into the uterus, only 27% of the time was there enough tissue there to give a histologic diagnosis in these people with that thin white line on ultrasound. And so in 2009, the American College of OBGYN said, quote, when transvaginal ultrasound is performed for patients with postmenopausal bleeding and an endometrial thickness less than or equal to 4 millimeters is found, endometrial sampling is not required. It took 20 years from the first observational studies suggesting this until the American College of OBGYN finally codified this application of ultrasound. So ACOG tells us if a blind biopsy is still done first, it is only reliable as a stopping point if it is positive, i.e. cancer or atypical hyperplasia. So this example from gynecology shows how ultrasound, when used first, is safer, cheaper, and better medical care than the old invasive approach of either biopsy or D&C. And there are examples of this from practically every field in medicine that really aren't mine, and this is a table from an article recently in the New England Journal of Medicine. You may or may not be able to read it. I can barely read it here, and I'm looking at the computer, but these are the specialties, and these are the ultrasound applications. And I put forth to you, the applications are infinite, as we just heard. If you put this technology in the hands of people and let them use it and decide what they can see and how they can apply it to what they do, it can be breathtaking. The bottom line is increasingly we should be thinking ultrasound first. And just so you don't think I leave you without clinical follow-up, 6 weeks postpartum, she was back in New York Harbor holding up the torch. What you can't see is there's a little bridge down here nursing. Thank you very much for your attention.